As John said, when we planned the programme, it's quite an undertaking to try and curate an interesting collection of input, and people can bring different insights. And we thought it was an excellent opportunity to hear from the new Chief Medical Officer about a really important area, which is not coronavirus. Life goes on, and in particular, multi-morbidity goes on and grows. So we thought it would be a good opportunity to explore some of these issues. You may have seen Professor Whitty's article in BMJ earlier this year. It's one of our biggest challenges. But we will have just allot a very small bit at the end of his presentation and the Q&A to pick up the issue of the moment and ask him to say a few words about that and answer a couple of questions. So if you have questions about that, just save them because we will get to them. But first of all, let's hear from Professor Whitty about the main topic that we asked him to talk about, multi-morbidity. Professor Whitty, thank you.
So actually I was given an even wider topic than the multi-morbidity. I was asked to talk about health over the next 20 years in 20 minutes. So I'm not going to take any prisoners. I'm basically going to go through data to make a few points which I think are sometimes underappreciated in health planning and decision making, because that's very much the audience I'm talking to. And I'm not going to explain things like demographic pyramids because I'm going to assume that everyone in this room knows what they are. So I'm happy afterwards to give a epidemiology lesson for those who need it. This is the demographic pyramid for the UK from 1911. I chose that year because if you go in any further, you get into the world wars, comparing it to roughly where it is now and roughly where it will be in about 25 years' time. And the first thing to say is the change that we had demographically over the last century was massively greater than the one we're about to get. But the one we're going to get, of course, is very important. But, and this is the important but, I think a lot of people do not realize that if you look at the rest of Europe, the demographic pyramids mean that they are going to have a much harder landing in terms of actually aging than the UK is by some distance. And these are the demographic pyramids for Germany, Italy, and Spain. Almost all of those, the middle bulges, are between 50 and 60. And of course, those people are about to retire, and then they will get ill health. The reason I'm making that point is we have always assumed that if we got our planning for our numbers of doctors, nurses, and healthcare workers, social care workers wrong, we could actually basically buy them in from our nearby continent. The competition for resources on this is going to go up very substantially over the next few decades. And that's also true if you look globally. This is a very famous and important slide from Hans Rosling, the late Hans Rosling. I'm not going to go through the multiple important points on this. He mainly used it to illustrate the point that actually the wealthier a nation, the better its health outcomes. But every country in the world is moving from bottom left to top right. And if you look forward 20 to 30 years, most of the middle-income countries will have a health structure and burden of disease which is pretty similar to our own, but with some additional ones which are legacies of the fact they're lower-income countries historically, and therefore they also will be in competition for social health workers and others. So I think we need to think quite seriously that our ability to buy in things when we get our own planning wrong is going to decrease over time, and we need to plan on that basis. The second point, internal migration. The debate tends to be around external migration. That is actually for health much less important than internal migration. In the UK, in general, we have a pattern where we move into large cities at the age of 18 for to either be students or work, and we move out of cities after our second child. That's very stereotyped. You may not do this, but if not, you're the minority. The result of that is that what you get is the cities remain eternally young. Their demographic structure stays the same, but the equation has to balance. And therefore, the rural and small town areas are getting older at a much greater rate than you would expect from any of the overall projections. So I've just illustrated this, and I could have done this in any combination of a city and its rural hinterland. This here on the right is Newcastle, projecting forward to 2037. These are the ONS data. On the left is Northumberland. Everybody in the bar on the top left is over the age of 90. And the same would be true, for example, if you look at Leeds and Harrogate. And the same is true for London and its hinterland. What does that mean in practical terms for us as a country? Well, this is the map of the UK when I qualified in medicine, roughly now, bottom left, and where it's going to be when I retire, provided the retirement stay the same as expected to be. And what you can see is the large increase in people over 85, where the health needs will be, are in the rural and small town areas. And yet these are ones which it is often harder to attract health staff to, harder to attract nursing staff to, harder to actually provide hub and spokes for things like door-to-needle times for stroke patients. So we're going to have to take account of this shift of burden of disease towards the rural areas over the next 2 decades. And that's going to be exacerbated because what we're going to end up with is a gradually worsening working age to retired age ratio over time. So this is if you put that and you layer that on top of the fact we're going to be in competition for people who are health and social care workers with all around the world, I think this means we have to think very seriously about this now if we're not going to get into an extremely predictable problem. The exception to this, the one major exception to this, apart from a few diseases which tend to be higher in people of some of the ethnic minorities, is mental health. Mental health does tend to cluster in towns, and always will, in my view. And that is basically because people tend to acquire mental health illnesses in their late teens through to the early adulthood, and then they continue after that point in time. So that is the one thing where that is less true of. So the next point I wanted to make was about the concentration of mortality. If you look over time, these are data back to the 1850s, because I think if you want to think about the future, you have to think about the past. And what we've seen is a steady concentration of mortality over a very, very stereotyped part of the age spectrum. So it used to be that you'd of course die in childhood, that's well known, but you could carry on dying all the way through your life. Now it is incredibly rare for people to die under the age of 75, in our society, and very rare, actually, still, for people to die over the age of 100. And the concentration is getting tighter and tighter as time goes by in this increasingly stereotyped way. And if you look at the more recent data, if you look at changes in mortality, the light blue line at the top there is people over the age of 90. There has not been an improvement in mortality rates in people over the age of 90 for a long period of time. Whereas the bottom one is the change in mortality people aged 75 to 79. That is continuing to improve at quite a rate. So what this shows is this concentration of mortality is going to continue over the next 2 decades, and there are significant implications for how we provide the health service as a result of that. Now, the way in which the health service is configured has changed throughout its life course, and it will continue to change. The biggest shift in the NHS, which again I think many people don't realise who have not looked at this, is the huge shift from a bed-based service to essentially an outpatient-based service. And what you have on the left in these brown things is the NHS when it was formed, and on the right where we are now. And the number of beds in the NHS has gone down, even though the population has actually gone up. The situation has completely refigured for many diseases. I'm making that point because the next point I wanted to make is one of the things that I think is one of the biggest threats to the NHS if we do not sort it out. There is a belief by my own profession that the reason why the rates of pressure on the service are going up is entirely due to aging. This belief is wrong. There is an aging component to it, but if you look at these OBR data, this is the rate of increase in outpatient activity every year. And annualized every year, the rate of increase is between 5 and 7%, irrespective of age. Because what you got on the right there is the different age brackets. And therefore, this increase in demand for outpatients, which, as I say, is the direction of travel for most of healthcare, is something which is being driven not by age, but by other factors. And I think that is an issue we need to think about very seriously, because if you're compounding up at 6 or 7% a year, you're talking about really quite serious numbers. Now, I wanted to just touch, before I move on to individual diseases, on life expectancy at birth. It's an observable fact, pointed out by Michael Marmot correctly, that life expectancy at birth has stalled in the UK. And these are the data over time, and the graphs are pretty stark. That's a fact. It also coincides with the economic shock. And my own view is linking those two together seems a perfectly reasonable thing broadly to do. What I am much more uncomfortable about is people then linking it to individual policies of individual governments. And the reason for that is this. These are, I've just chosen the 4 largest countries in Europe, and basically the graphs look the same. So over-interpreting this bit of government policy caused it strikes me as intellectually quite weak. Most of the change that you either see or don't see is in this age 69 through to 80, broadly. And that's the area where it has ceased to improve more recently. And I think a lot of that change was due to changes in cardiovascular disease, which I'll come on to. So now a little bit about individual diseases. The patterns of diseases that we have to deal with change the whole time. At any point in time, the professions and the public believe that the current burden of disease is what is normal. Actually, these change very dramatically. And I'll just give a couple of early historic examples before I go into my own views about where we're going to go next. These are broadly infectious diseases in the dotted lines, cancer in the dashed lines, which I'll come on to last, and cardiovascular disease in these solid lines in the UK over the last 100 years. And what you can see is that if you went back 50 years, cardiovascular disease absolutely dominated all other forms of mortality by a very, very large amount. And now we're in a situation which has come down a very long way and is continuing to do so. I'll come on to those data. Infectious diseases, my own trade, dominated very heavily at the beginning of the last century. It's going to dominate again in the future, because if you don't die of anything else and you're an elderly person, that's what you die of. But at the moment, we're going through a bit of a lull. My own bit of trade has done a good job. But if you looked historically at the NHS, when it was formed, all the things in green are people dying of infections, and all the things in blue are people dying of cardiovascular disease. The NHS was dominated by infectious diseases in its early years, and it is only more recently that other things, first cardiovascular and now increasingly cancer, have come to dominate mortality rates. That trend, in my view, is going to continue, although I think the cancer rates, for reasons I'll come on to, are likely to go down. Now, just to unpack a few of these data, and I'm going to go through these quickly because most of you know these data, but I want to make a general point. Lots of people do mathematical models, and lots of people do things where they read the Nature and the New England Journal of Medicine, and based on the latest paper, they predict what the changes in medicine will be. My view is the best way to do it is to look at the data from the past and use a ruler. If you look, I'm just going to go through whole bunches of bits of data, and I hope I will make my point reasonably clear. These are the changes in coronary heart disease rates in the UK. These are the changes in stroke rates. Now, just have a wild guess where that's going to be in 20 years. You can try and model it, or you can use a ruler. I think the ruler will help. And cardiovascular has been one huge success story. Because are based on drugs which are now off patent, they're now competing, so the number of drugs has gone up over time, but the cost of drugs in cardiovascular disease has actually gone down. This is an area where we're getting healthier and it's getting cheaper. And the good news just keeps on rolling on with cardiovascular disease, because increasing amounts can be done relatively non-invasively, which previously required major operations. So this is basically cardiovascular, a phenomenal success story. Doesn't mean that there isn't further to run. This definitely is. That, of course, though, means a group of people who would have died of cardiovascular disease now are not dying. Excellent. And that is the reason why we're getting a very large increase broadly, and this is simplifying but not much, in dementia. The incidence of dementia is not going up. The rate of dementia is not going up. In fact, if anything, it is in fact going down. I'm about to show you those data, but the prevalence is going up because once you've got it, you've got it. And a lot of these people would have died of cardiovascular disease before. Until we sort this out, this is just going to carry on going up. So this is a really major target for science because there is no other route out of this one other than scientific advance in this area. That's not to say there have been no changes. These are interesting data from Matthews et al. It's one study, but I think the best study I know. And what it demonstrates, if replicated, is that the rates of incidence of dementia have gone down quite substantially in men and hardly at all in women. In my view, probably because the vascular risk factors are also the same as the risk factors that drove quite a lot of dementia in men. So if you remove those risk factors, then the dementias improve. But this is not going to solve the problem, and as you can see in women, there's been hardly a change over that time. What this means for the UK geographically is that over time we're going to start moving from the biggest burden of disease being in the areas dominated by cardiovascular disease, particularly around smoking, to the biggest burden of disease is actually going to be in areas of older people for which dementia is a proxy. And that's going to shift the geography of disease in the UK in a predictable way, which I do not think we are currently planning sufficiently for. Then cancer. Broadly, you know, there's prevention of cancer and there's treatment of cancer. For the cancers at the top of this, which is, includes the major diseases of men and women respectively, prostate and breast cancer, treatment has improved dramatically. So over the last few decades, we've moved from a situation where only 25% of people would be alive and well after 10 years to a situation where it's now 50%, and that will continue to improve. The failure, which I'll come back to, is right at the bottom, and that is lung cancer. Right, back to our rulers. This is survival over time. The last bar, incidentally, is half decade, the others are decadal. And what you can see is these are 10-year survivals, which I think are the most important to look at. For prostate, breast, bowel, melanoma, again, use your ruler. Guess where these are going to be. Hodgkin's lymphoma, leukemia. And of course, sadly, for the ones that do badly as well, you can also predict where they're going to be. This is lung cancer, a disease which is basically a cancer entirely for profit. So if we look at that's success, but the bad news on this is that this is not an area where we're losing large numbers of drugs that are actually coming off patent. These drugs are still all on patent. The science is developing rapidly. They'll carry on being on patent. And if you look at the cost of these drugs, these are data, I've just presented them from that well-known socialist rag, Fortune magazine, and it's making the point that to buy 1 year of life from cancer, inflation normalized, we've moved from a situation in the US, the UK data are slightly different, but the trend is the same, where it was just over $50,000 per life year to one where it's now over $200 per life year. We haven't bought anything with that increase in cost. That's just an increase in cost. That's inflation adjusted. Bit on prevention, smoking trends coming down too slowly, but they are still a way to go, and much of the remaining inequalities, the kind of things that Michael Marmot was highlighting last week, a lot of the avoidable differences are driven by smoking. The occupational, if I'd been given this talk 30 years ago as CMO, I would be talking a lot about occupational diseases. The last of the great occupational cancers is now peaking this year. That's the epidemic driven by asbestos, which is a combination of mesothelioma and lung cancer, 50-50 basically in terms of the roots. All the others are much less important. Accidents have gone away. The thing we're not doing well in workplaces is health improvement and health promotion, where I think we really need quite a radical shift of direction. But stopping people dying because of work, we've really got very good at. Stopping people being healthier because of work, we have not. And then a couple of other preventative areas. Pollutants. Things are not as bad as they sometimes appear, but the fact, that most of the pollutants have got better, but this hides the fact that actually the rate of improvement is less good in the parts of the country where people live. So in cities, the rate of improvement in pollution is much less good than it is overall. Having a really polluting factory in the middle of a field become less polluting is great for the environment, but doesn't actually have much health impact. So the cities is really where we need to think about. Screening and vaccination of cancers, I'm not going to go into in detail. Very happy to pick up in questions. The 2 points to make are, on this I just wanted to make in passing really, were screening really works in cervical cancer and works to some degree in breast cancer. And then there are some things in terms of genetic diseases in neonates. Much of the rest of screening is highly controversial, and many of the things people talk about for screening actually will do active harm. Nobody's going to screen me for prostate cancer anytime soon, because the probability is it will lead to me having unnecessary, rather unpleasant procedures, and it has absolutely no impact on mortality. The same is true for many other areas. We need to think about this in a much more sophisticated way. And then there are a bunch of cancers which are going to get rid of by vaccination. HPV, being the main one for cervical cancer in the UK, globally, hepatitis B and C driving most of the liver cancer in many areas, and in my own view, potentially Epstein-Barr virus drives a number of other cancers, which I think are probably preventable. Before I come on to my final section, just to acknowledge that the stunning improvement globally we've had has been in child and infant mortality, but in the UK we've continued to have an improvement, but it's been relatively slow, and neonatal health remains not in the best group in Europe or the world, and we ought to be thinking about that, I think, quite seriously. And obesity, I'm not going to go into, I'm just acknowledging that's a growing threat, which I think has been talked about enough. I don't have anything new I wish to say about it today. The final point I wanted to make before I just summarize is about multi-morbidity. And this is what our chair talked about earlier on. You know, we all know that we have not bought a healthy year of life for every year of life we bought. It varies around the world how much you get, but for every year of life you buy, some of that is an unhealthy period. I think what is less widely acknowledged, although it's now well known, is the fact that as you grow older, you actually get a lot of increase in multi-morbidity. And the shift of medicine has been from single diseases, where the big benefits have come from specialization of the medical profession, and we're moving over to a multi-morbid era, where most people who have either got no diseases or lots of diseases, where specialists with no generalist skills are probably not the right doctors and nurses to have. We need to be going back to an era where people who can maintain their specialist skills but retain their generalist skills. If we do not do this, you're going to have people coming with 6 diseases having to go to 6 specialists, none of whom talk to one another. This is a problem for the medical profession. It is a problem the medical profession has got to sort out, in my view, over the next 2 decades. Preferably over the next 2 months, but that's probably a bit optimistic. Finally, just to acknowledge that occasionally things come along, however good your strategic aim is, which knock you off course for a while. We're not heading into an H1N1 1918-20 flu pandemic situation, but the coronavirus does present some challenges for us. It definitely will for a period. How big remains to be seen. But you know, the events happen, and when events happen, the great majority of them tend to be infectious, and we're seeing an example of that at the moment. So, my summary. There are a lot of areas where we are winning, and if we just continue doing what we're doing at the moment, we will continue to win. They include heart disease, stroke, much cancer treatment, some cancer prevention, smoking, albeit slowly, child health, but not neonatal in my view, and urban health. All of those areas are going really well. And then there are some areas where we could win, but on current trajectory, in my view, will not, which include multi-morbidity, dementia, frailty, often mistaken for multi-morbidity, is different, mental health, which I haven't talked about much, but which has been really, really disappointing how little that has improved, although there have been some major improvements. Obesity-related diseases clearly heading our way. Sally Davis would kill me if I didn't add antimicrobial resistance. Getting the demand-supply ratio right and understanding why there's been this phenomenal increase in outpatient activity when that doesn't really appear to have medical logic, and one which I think I am really worried about, rural health. Thank you very much.
so we'll open the floor, but we've got a couple of responses that I thought we'd just ask people to provide us with. Jennifer is over here. Yeah, Misha, I'd like to take this. Thank you. And Jennifer, I think we asked you to give a few responses to that tour de force, which is...
Thank you. I'm the plant here. So thank you very much, Chris, for your very, very interesting set of slides. Just something slightly different. And that is the Marmot review you referred to this week came out. Stalling life expectancy, we know. But also, as you also know, life expectancy going into reverse for some communities, not least women, but also for men in some deprived communities. Growing gap in health, not just between rich and poor, but also between poor and poor in the northeast compared to poor in London and the southeast. So my question really is, how do we effectively address this? We haven't had a health inequality strategy for a decade. Is it now time for one?
Yeah. Thank you. So, firstly, the fact of the inequality difference in mortality, and even more actually severely in morbidity, if you look at that, is an observable fact. Lots of people have described it. Michael Marmot's described it probably best, but there are many other people. Many fewer people have actually described a situation where we can deal with it that is both likely to work and realistic. And I think this is a big challenge for us to deal with. I think it's best dealt with by taking the groups in society in manageable problem sets that cluster together. So, for example, this year I'll be doing my annual report on rural health, where I think there's a group of issues, particularly around ageing, but there are some other ones, and coastal towns, because there is more in common between Blackpool and Margate than there is between either of those towns and their nearest inland neighbour, for example. And we should see those problem sets and see them as a national problem and deal with them as a national health priority. Now, many of the solutions will not be in the health sector, but I think if we divide them up into problem sets, we're much more likely to address them than if we simply say, well, these geographical areas have got big differences and what are you going to do about it, which I think has slightly been the tendency to date.
Great, thank you. Chris Naylor, I haven't seen you. Yeah, excellent, good. Thank you. Just probably introduce yourself if you would, please.
I will do.
Yeah.
Hello everyone, my name's Chris Naylor. I'm the Chief Executive of London Borough of Barking and Dagenham, East London Borough. If people can't picture where it is, it's the bit on the EastEnders map they never quite get to on the telly. So thank you very much for that. Unfortunately, I broke my glasses at the weekend, so I couldn't quite see all of your slides, but I got the tenor of your argument. And I think the point you were making about let's not hook all of this onto austerity was right, and I'm not quite paraphrasing what you were saying. And I say that as a person who runs an organisation that's had its budget cut by 62% since 2010, and where I observe that the parts of the system in my locality that are most under pressure are those bits that haven't had any austerity at all. I suppose the bit for me really is, my authority is one that's gone through profound change over the last 30 years. We're sort of post-Fordist in all senses of the word. Like we used to have a massive Ford factory as well as that employed 58,000 people, now employs 3,000 people. The economic fortunes of the place have changed dramatically. In 2015, when I started working there, the average healthy life expectancy of women was 53 years old, 25 minutes away from the most successful city economy on earth. We've been doing a lot of work recently with health colleagues to understand the journeys of people into acute services, my services, their services. And the data tells us, and none of this is rocket science, it's people with low pay, people experiencing debt, interestingly enough, is a big trigger for people, mental health, etc. I guess the point I'm sort of rambling towards here is that if I take my ruler out and look at the sort of national finances, in sort of 10 to 15 years' time, unless we radically alter the trajectory of spending on health and social care, I think the wheels of our economic settlement in public services, they fall off. Because I just don't think our economy is going to grow sufficiently to meet that rising cost. I don't think there's any appetite to see the level of taxation rises that we would need. And in any case, I think that would be probably a finger in the dike. So I guess the kind of the question in all of this, I think it's certainly for the local government world, we've had to shift our stance away from meeting need to trying to understand in quite a radical preventative way root cause. And I think when you do that, there are questions about housing and employment and economic distribution, sort of structural barriers that hold people back, which are the key to unlocking a lot of this. I don't know what your thoughts are on that.
Thank you.
Well, I think the short answer is yes. I mean, that is clearly right. One of the questions for people like me is, so what's the role of local government, what's the role of central government in trying to address these serious issues? And that's one of the reasons I think it's worth thinking about problem sets and taking geography out of it, because central government does have a role. I think if you've got a common problem set across the country, it does not have a role if something is a very, very local problem, which we much better understood locally. So I do think we need to try and get those to work together. I should also say, I think there's a bit of I have a concern that the amount of research that goes on in local authorities is very small. This is not the fault of the local authorities. This is a structural problem, and we need to sort that out because the evidence base is not strong enough in many cases to be able to point to a solution and say, we're pretty confident this is going to work. And so I think that's an area we in the centre ought to be absolutely helping local government in addition to more practical things.
Oh, interesting, yeah. Okay, Ingrid, here.
Thank you very much indeed. Really interesting talk, which I'm sure everyone enjoyed as much as I did. I wanted to just ask you a few questions about the child health point, because you said that it was in the winning category, which I sort of agree with. Things are getting better, but I also sort of disagree with. Partly because of the things that are worrying me. One of them you picked up on, which was infant mortality. And it is ticking up now for the last 3 years, but most worryingly is it's ticking up only amongst the poor. So that speaks largely to the Marmot report yesterday. So that's one thing that's worrying me hugely. And then the other one is that if you look at all other ages of child mortality, and you compare us with European countries, we are declining, so it's a good news story, and this is where I agree with you, but we're not declining as fast as in other European countries, and that's where I disagree with you, and I'm worried about it. What can we do about it? I think it's partly NHS, partly not NHS, of course, but, and here's my question, as regards what you showed about the demographic shift, and the emphasis on the elderly and all of those urgent drivers about social care and absolutely legitimate problems. What impact do you think that will have on the attention that child health gets, and what do you think we can do about it?
Well, the first thing is to say, I'm glad to say we're agreeing on both points, because I actually made the point that, in fact, we're not in the leading pack, and we should be, because if you can do it in Finland, you can do it here, broadly. In terms of child health, I think we need quite a significant rethink on child health. I'm really worried about what's happening in paediatrics. I'm quite worried about what's happening in quite a large number of areas of child health elsewhere. And I'm also worried about what's happening to the intellectual underpinnings here. Academic child health is going down rather than up, and this is something which I think is clearly a serious issue for all of us. So I broadly agree with the problem set. The solution is not, I don't think there's, to be honest, I don't think there's a huge competition for resources between children and elderly care. I think that the difficulty occurs in the bit between those two, and that there I think the competition probably does become more of an issue. But most of the public and most politicians wish to protect child health, rightly. I think the problems are more to do with the fact we haven't systematically done all the things we know work. Because most of the things that would get us up to the top of the leaderboard, we know what they are, we're just not doing them systematically.
Would you expand just a little bit on your anxieties about paediatrics, because that's kind of intriguing. I don't think I don't want to leave that hanging. Do you mind? Is that okay?
Yeah. If you look at sort of vacancy rates of paediatrics, if you look at movement into that area, it's really going in the wrong direction, and there are a number of reasons for that. But it's quite a worry, and it always used to be that huge numbers of people really, really wanted to do paediatrics, and that ceased to be the case. It's not really obvious why. I could hypothesize, but I think we need to sort that out, because this is an area which, many other areas of medicine, people can switch between a lot more easily than they think they can. Switching between adults and children gets a lot tougher. And so if you don't get your workforce right on this, you have less ability to apply a kind of gear change in flight.
Yeah, excellent. Claire, and then there's a lady here at the back.
Thank you very much for mentioning generalism. The late Barbara Starfield, who I'm sure you know, the famous academic researcher from America, did some fantastic studies that showed that the more GPs, they weren't called GPs, you have per head of population, the better the health outcomes of that population, irrespective of the numbers of hospitals and all of this. So it was an independent factor for the number of generalists. what role do you think the CMO has in trying to work with the medical profession and Health Education England to try and improve and reach Matt Hancock's, I think, very good target of 5,000 more GPs? I think we actually need 10,000 more GPs. But also to reduce the increasing subspecialisation, whereas as a GP now it's virtually impossible to find someone that, other than geriatricians actually, who look after the totality of the body. So what? Because you said in passing that was for the medical profession, but what role do you think that you have? And fabulous talk, thank you very much.
Right, so two things. I mean, firstly, I think that I and all the leadership of the medical profession, many of whom are in this room, have a responsibility to say, look, we all accept that the move to specialisation is fine, provided you retain generalism. It is not fine if you lose it. And several people in this room and others, for example, co-signed an editorial in the BMJ making this point. I see, for example, Bod Goddard in the audience, others, making this point really clearly. We've got to do something about it. This is in the gift of the medical profession. And CMO is one of the leaders of the medical profession, but there are many others. And I think we collectively have got to sort this one out. On GPs, the bit that isn't my job is trying to balance the books and try and get all the numbers right. The bit I do consider is my job and to worry about is that if you try and do it really fast, the danger is you'll get GPs into the places that are already GPs. And actually, my big worry is that if you look at the map of the UK of medical need against general practice, this is not an even distribution. And there are bits of the country which you go to, and they're lovely areas. You think, why would no one want to work here? You know, let's say you go to Margate. They're really struggling to fill every vacancy. So I think that the bit which I should be adding in is let's think about the areas where we really need them even more than we do anywhere else. Take your general point.
Great. Laura, was yours a coronavirus point or yeah, in which case, can you hang on to it? And we'll, I think I've got Anne-Marie Rafferty and this gentleman here. I can't see who you are. I'm sorry, the light is... do you want to put your hand up and someone will get a microphone to you? Yeah. And then there's Anne-Marie. Yeah. Anne-Marie, do you want to go first? Yeah.
Yeah, cheers. Anne-Marie Rafferty, President, Royal College Nursing. Thank you for a fabulous talk, Chris. My point was on geography, which Nigel had alluded to earlier as being one of the neglected areas that we that we under-analyse in healthcare. And just thinking of your rural and coastal towns areas, what can we do to actually incentivise people to go and work there? And would you consider pay systems to be part of that? And if so, would you be petitioning the Secretary of State to change the pay systems for nurses as well as doctors, possibly?
Right, so I have two general principles, which is I never talk about money in public. My advice on money is private because it becomes in the political sphere, and the other is I don't talk about individual patients, which may be relevant to the coronavirus questions. But other than that, I do consider this as an important area to think about. I think I understand the medical profession better than I understand the nursing profession. I'm clear about that. In the medical profession, the biggest predictor of where people work is where they train. Yeah. And so I think that what we really need to be doing is getting training into the bits of the country which are actually weak at the moment. And I think that will, over time, now that doesn't solve the problem in the short term, but I think in the long term, that is probably the more durable solution as to how you do it. Pay differentials and so on tend to be relatively quick fixes, which very often are surprisingly undurable.
Yeah, I think Luella, we've done some research on that we can share. It's not the most effective method. And there's also the question about, do you want to live and work in these places? Gentleman here, yeah.
Yeah, so that was timely.
Say who you are, please.
Yeah, Jihad Malassi. I'm a GP part-time and clinical chair for Thanet CCG. Yeah. And I'm also, with my other hat, clinical director for Hospital Transformation Services. And I want to thank you both, Anne and Luella, for coming to Thanet, for helping us with our hospital work and with our general practice PCN type work. Actually, you stole my thunder in a way, because I wanted to know what the strategic view is on how we link up what hospitals provide as anchor institutions, as well as looking at coastal deprivation, the indices that you've described, and putting that in a package that we can deliver nationally. I don't know what your view is on that. I feel that locally and regionally, we've done everything that we can possibly to recruit, to retain, to make life interesting, to offer dynamic jobs that cross sectors, that share jobs between secondary care, community care, mental health, and so on. And now with the new university opening up its medical school branch, I think that will be an exciting innovation and an exciting jewel in the crown, as it were. But that's another 13 years before we get somebody at the end of that pipeline. So what is our answer to that?
Well, I think that, well, thank you. And again, enormous admiration for the work that you and your colleagues do there. There are no easy fixes on this, but the two things I think we need to start doing now, and someone, for instance, called it out from the audience, I didn't see who it was actually, but they made the right point, which is what we've got to do is make this an attractive place to go to, and then an attractive place to stay in. And I don't actually think we really understand the drivers. And I think I get an awful lot of people coming in and telling me this is the thing which people really care about. And A, they almost never have any evidence, and B, they all have a different idea. So this is something where we actually basically need to ask the question, and then we need to arrange the incentive structures around the things that people really care about, and use that to rebalance the system. If pay is one of them, fine. My own view is it may well not turn out to be a terribly strong part of it, but we have to go with the incentive flow, because we're not going to tell people where to go. They have to be invited to go and wish to stay.
Yeah, absolutely. We had a session this morning about looking at technology, and I was just wondering whether you might reflect on what are your thoughts on the sort of burgeoning growth in various types of technology, everything from AI to new devices and new medicines that are coming on stream, and what sorts of aggregate impact do you think that's likely to have in terms of how we cope with some of the trends that we're seeing here?
What, in 1 minute?
Yeah, absolutely, yeah.
Well, I mean, let's start off with the Silicon Valley cliche that all technology is less important in the short term and more important in the long term than people think about.
We had that one this morning.
Yeah, I mean, which is broadly true.
Yeah.
There are some really obvious trends. I mean, AI, for example, clearly is going to be very important in pattern recognition. I mean, diagnostic radiology, diagnostic histopathology will be machine read within my professional lifetime, for sure. Quite a lot of the things people claim for it are not going to happen, pretty obviously. But if you look in aggregate, I think one of the things that is most striking to me is a lot of people assume that technology makes things more expensive. It doesn't. It actually can allow a less skilled person to do something which a more skilled person previously had to do. Now, a relatively quickly trained technician, or I, can do an echocardiogram and can be just as good as the cardiology consultant who's had 30 years of training in cardiology. And the same is true across the board. So I think a lot of what we should really in particular be concentrating on is those technologies that allow our medical workers, doctors, nurses, all the other professions to do their job better and quicker, and probably with less training, to achieve the same or better levels of healthcare. And that is a subset of all the things that are talked about. And my own view is that's where we should concentrate our fire. That's what will give us our biggest bang for buck.
Excellent, thank you. James, did you have a quick question? Do you want to? Our microphone. No, we do need to get a microphone to you, so perhaps if someone who's got one could, because the problem is it's live stream, James, so...
Oh, sure.
Yeah.
So James Mountford from the Royal Free Hospital. It's nice to have a talk where you think, well, here's 4 questions I'd like to ask about each slide. So I'm just going to pick on the outpatient one. And the long-term plan says, I think it's 1/3 of outpatient appointments we're going to cull. And your slide suggests that may be more challenging than we had realised. Could you expand on that?
Yeah. If you just let us assume you just take the data from the OBR as broadly right. I mean, you quibble about the exact details, but let's say 6% a year on average in every area. I do not believe we are getting 6% worth of extra health out of that 6% a year growth. So it's made up of 3 things. Stuff shifted from inpatients, good. Stuff that's new medicine, that's doing something which we previously couldn't, good. And utterly useless activity. Now, you can all work out which is only good if you're the person being paid for it. So we can all work out in our own minds where we think they are, and they'll vary by different disciplines. But I think we should be taking a very serious look at this and try and see if we can strip out that last bit, which I think is quite a considerable part of it, without impinging on the other 2 bits. And that's the art, I think, of trying to achieve this. This doesn't strike me as impossible to do. Like everything, it depends on observing what's done, working out which bits work, and stop doing the bits that don't work. There's not much to it, more to it than that.
Yeah. So shall we move on and just ask, I think you were saying, you make a few remarks about coronavirus, and I think there's Laura Donnelly who's got the microphone. But do you want to say something first before?
Shall I just do a quick summary?
Yeah,
just to situate it, and then very happy to answer basically questions and anything. I mean, the key point to make, which is an obvious point, but I think it can't be made strongly enough, is this is a global problem or it is nothing. So if this becomes a global epidemic, then the UK will get it. And if it does not become a global epidemic, the UK is perfectly capable of containing and getting rid of individual cases leading to onward transmission. I expect there will be some onward transmission in the UK. We haven't had it as far as we can see to date, but that's just a matter of time in my view. But if it is something which is containable, the UK can contain it. If it is not containable, it'll be not containable everywhere, and then it's coming our way. And at that point, we've got a strategy on this which has 4 tactical aims, and they're relatively straightforward. Contain, if we can contain. If we can't contain, delay, because we need to push this out into the period of the year away from winter. It also buys us some extra time to do research and understand this. It may give us some advantage because there may be lower transmission rates, in my view, in late spring through to autumn. So I think there are 3 reasons why delay is useful, but it may come at a social cost. Research, because we need to understand this better, otherwise we're going to have an inefficient response. This isn't primarily about new drugs and new vaccines. They're important, but they're probably for next year's thing if this becomes a major issue. But lots of things we can do now, repurposing of drugs, understanding, mathematical modelling, social science around this, and then mitigation for the health service so that the impact of the first wave, which will probably be the biggest, not absolutely, so definitely, is minimised because there will be a beginning, a middle and an end. And depending on how bad it is, the middle may be quite tricky. And we need to get ready and try and work out how we can actually basically front load or back load other activity. So the bit in the middle, that's what we're doing, and then it passes through. That's a summary of where we think we're going.
Great. Laura, you might just want to walk away from the speaker that you're sitting under for fear of blowing up the system. Yeah, thanks. Yeah.
Yeah, okay, thanks, Chris. You touched on a couple of things.
You need to just introduce yourself, if you would, please. Yeah.
Laura Donnelly from the Daily Telegraph.
Thank you.
Yeah, you touched on a couple of things I was going to ask about. Obviously, we're seeing a rising threat, and you talked about some of the measures to delay could have a social cost. So I wondered if you could sort of enlarge on that, and wanted to ask, when do you expect the first mitigation measures? What do you expect the first mitigation measures to involve if we do see an outbreak? And also, what could the public do to play their part in an outbreak situation? Would you be wanting to saying to people, try not to put pressure on GPs, try to avoid, be accepting of the fact that maybe delays, non-elective care pushed back? And I think you talked there about, front-loading activity or back-loading activity. So if you're able to expand on those scenarios for the NHS.
I think you've just sneaked in a whole load of questions there.
I'm not going to be able to do justice to all those questions. They're all very good questions, but I would need 20 minutes to give a proper answer, but I'll try my best. In terms, the most important thing from my point of view is for us to firstly work out, which we're trying to do through a combination of science and modelling, which are the things which could delay this or flatten the peak. And flattening the peak is very good for the NHS. It may not be good for society, and we're going to have to think that through. And some of the things we have to do are going to come at a social cost. Everybody knows that the kinds of things you consider are reducing mass gatherings, school closures, which may or may not be appropriate for this particular virus. We don't know yet. We need to find that out. There are several other things. Now, to be clear, we're not saying we will do them, but we have to look at all of them and say, how likely are they to work, and what's our evidence base here? What's the social cost of this? Because one of the things that's really clear with this virus, much more so than flu, is anything we do, we're going to have to do for quite a long period of time, probably more than 2 months. And the implications of that are non-trivial. So we need to think that through carefully. The biggest thing we can do at this point, I think, is there are things which work, or probably work, and there are things the public thinks on perfectly reasonable common sense grounds work, and they're not the same things. And it's very important that we try and make clear that things that actually don't work and have a big social cost don't work, and don't keep amplifying things which are actually just socially dangerous and not terribly useful, and push over to the areas where we're going to have to, as a society, have a serious discussion about how we're going to manage these trade-offs between, let us say, school closures and changing the shape of the epidemic. These are serious questions. I think as a society we're perfectly capable of having them, but we need to be aware of the fact that there's no quick fix here. This is something which is going to be done really systematically, thinking through cost and benefit for everything we do. And anything that colleagues in the media can do to help, in a sense, amplify the serious debate and move away from the what I consider is utterly trivial debate which just confuses people, I think is incredibly helpful. So I really would value help from people in doing this, because this is something we face as really quite a serious problem for society, potentially, if this goes out of control. It may not, but if it does globally, then we may have to face that. So that was a kind of a bit on the social things. And so remind me the other ones, because I was so keen to answer that one properly.
Well, just before you do, would you just enlarge a little on what are these areas of sort of mythology and mistaken analysis?
So, for example, I think there's a perfectly reasonable belief by the public that if we just banned a few flights, that's going to solve the problem. Actually, the modelling shows even if you banned a lot of flights, all you would do is delay things by maybe 15 days. If that was a huge amount of ban, that would be a lot of banning. But this kind of keeps on coming round and round and round. And yet there are things which really, really work. So this goes back to the other points. I now remember the episode. There are some things that really, really work. And by far the biggest two are actually washing your hands, which people underestimate. It's incredibly powerful, I'll come on to why, and preventing, if you cough and sneeze, putting a hand in front of it, hopefully with a handkerchief in charge of it. Why is that? Because there are only two ways this gets into you. By breathing in someone else's air, which they've coughed, that's for them, that's why you want them to put something in front of their mouth, or through your hands. Your hands are by far the biggest way in which you get germs from somewhere else into your mouth or eye, and that's the way you get infected. Everyone touches their face the whole time. No one else touches their face apart from their intimate partners. It's your own hands that do it. That's why washing hands really, really works. Washing hands protects other people, it protects yourself. And so the debate should be around these things that really do work, where people really can help. And the same is true about stopping coughing, stopping droplets getting into the environment, particularly in closed environments like these. Rather than on many of the other things where people, perfectly reasonably believe they're going to work, but in reality they don't.
Great, thank you very much. Brilliant tour de force talk and also summary on coronavirus. So we get 2 for 1. Thank you very much indeed. Thank you. Brilliant. Yeah.